Pretty good.
Oh, did they help?
Someone want to hear a cycle? Yeah.
Double check my email.
Oh, no.
Usually I'm very
I-
helpful.
yeah.
All right, first item is to review our minutes, so you all have emailed the January minutes, and there's copies up there, can you need a copy? Take your glance, and if somebody's ready to motion for acceptance of the minutes, we are here.
So moved.
Thank you. And a second, great.
Albert and Sarah, any discussion or anything? If not, we will vote to accept the minutes. Everyone in favor? Aye. Opposed? And abstained. Awesome, minutes are very much. Yeah, it was a good meeting. Lots of conversation last time around. All right, so we are then moving into commissioners report, Dr. Murray.
Yes, so wanted to lead off with the Jewel settlement funding conversation. So I can confirm that the county has received an initial amount of $860,000. This constitutes the first 3 years of the settlement payout. Monroe County is slated to receive $2.2 million, but I do not have a timeline for when or what the cadence of receipt of that money will be. Hoping Brendan would be here so I could
Yeah.
but and so I have had an initial meeting with lots of people, my epidemiology team, and they have met with a number of school district representatives who work on prevention, and they are often talking about the youth behavioral risk survey, but it was a very natural group to discuss the fact that they will get the funds and what do you all think would be beneficial. So they are collecting that information, and we've had one initial meeting with the county executive. We proposed a number of different things, and so certainly one of the main priorities that we have in the Department of Public Health is to get input from the impacted folks if we're going to ever plan any kind of initiative. So pulling together some kind of a community advisory group or team to get their input. There are lots of academic partners who have worked on tobacco who might be researching vaping that I'm reaching out to the folks that I know to hopefully get us in touch with. And certainly representatives from the 2 hospital systems, the Center for Community Health and Prevention, which has their treatment clinics and whatnot, to find out what is already happening and what are some of the gaps or holes that we can use some of these funds to then fill. Some of the 4 ideas, concrete ideas that have been discussed, certainly one of them being a county response could be to use some of these finances to update signage to indicate, these are smoke-free and vape-free settings in buildings, potentially moving out into parks and other spaces like that. Just the purchasing of whatever those materials are, whatever costs would be associated with that. There's been a lot of success with the opioid multimedia campaigns about fighting the stigma and the Good Samaritan law, and I'll be excited to share hopefully some of those videos with you all. But that taking a similar approach with anti-vaping or education for the community, connecting folks to treatment. So what we currently have are short and long form commercials that some of you may have seen, Facebook kind of, ads that come up that can be geocoded to specific areas where there's high rates of vape use, bus placards and, the bus shelters as well. And so we certainly have found that very successful, and especially this last opioid campaign about the faces of recovery. We're really showing like anybody can develop a substance use disorder, but recovery is possible, and trying to instill that hope in what is often a hopeless period in one's life. So using certainly focus group data and other sources of information to craft some messaging and pilot testing it with small groups. It'll be interesting to do this with the Jewel money because it's specifically meant to support and impact youth faith behaviors, or folks who may have been exposed to electronic nicotine devices while under the age of 21. So I think we might use that language if the lawyers allow us to also work with adults, because so many people often are exposed to a lot of this advertising in, before the age of majority. We want to take a second and show those videos.
I can show.
Opioids, one on the back.
You need me to talk to, sorry.
Oh, you first. You were first.
I was just gonna say, similar to your question about leading the catchment of like schools. I know me and Aaron work a lot with school-based, health, so in schools, and then U of R has formed a youth and care advisory board, because I was on with pediatrics that we're part of. So just wondering about those avenues. Love the billboards, but it seems like the increases in schools with youth with vaping, like how do we get the catchment area with the schools?
Yes, so we'll talk about that after we share some of these videos.
Before we show the videos though, I'm sorry, new folks popped in, so
Yes,
we're in the middle of a conversation about dual funding that we received as a supplement at the county. And you guys are
No, Bridget Cook is.
You're actually
in the law department.
Yeah, that's it. I'm like, I think we met you.
Yeah, I was here last.
Great,
Nice
thank
to see
you.
everyone.
Yeah.
Yeah. Hi, I'm Alexis. I'm a research assistant at the Human Behavior and Social Change Lab on the River campus at U of R. Our research is mostly like trying to see investigate how psychological levers of behavior can be used in like interventions. So a lot of like changing behavior for human health in the lab setting, and I'm just curious to see more on the policy and administrative side how that sort of plays into it. So perfect. Yeah, see you everybody.
Thanks, you.
Conversation will be right up here.
There you go. Dr. Melissa Brown is our commissioner, so she's in charge and she's the giver.
Yes.
All right.
So this is 20 minutes long.
People, when they're actively using and drinking, think my life will be boring without drugs and alcohol. It's unbelievable how rich and full my life is now, and I never would have expected that prior to getting sober. Recovery is possible. Treatment works.
Did you want that longer one? I can do that whole one.
There's a bunch of that, and there's always such a rich conversation.
Great.
And there's some in English and Spanish and ASL, so.
I never thought my recovery would mean I'm running marathons or climbing mountains, but that's a huge part of my recovery. A little progress each day adds up to big results. Recovery is possible. Treatment works.
Started using opioids when I was in the military. I had a craving and a love for that more so than life itself. I was in active use of substances for 25 years. My biggest barrier was me accepting that I need to change and accepting some of the things that I have done. I never forget, I've been clean now 6 years. Never thought I would be in the place where I am financially, or even in a marriage, even have children. Addiction does not define me. Recovery is possible and treatment works.
So it's important to have an African-American gentleman in the African-American imaging, because some of our older African-American population has been overdosing to a disproportionate rate in years past, so.
Show you some of them.
Really good colors, any positive chat, like the slogan and the colors are good too, yeah. Very vibrant.
Officer
Oh, we're in the neighborhood.
and thought that he was unresponsive. Went back to his car, got a Narcan, tried it on the guy, it didn't work. He got another one. That one brought the guy around. The officer definitely saved his life. So when they came to me, when the county came and asked me if I would put a box in the bar, it seemed like a logical thing to do. You know, it's something I didn't know anything about. Now I do. It's something that should be out there. You know, I mean, nobody should think that it makes their business look bad by having it on the wall. It's a community service. Well, I had a mom come in and ask me if she could take some. And I had to think about it. I go, well, for what? And she said, well, my son. And she goes, they have parties, you know, and the kids are around and I worry. I don't know what they're always doing. And so I said, yeah. So she took it. And when she came back She said it wasn't for my son, it was for one of his friends. She goes, the fire department and the police said that if I didn't have that on hand, he never would have made it. Good chance we would have lost him. And I was like, that's great. You know, it worked. So I'm thrilled to have it in my business because there's a lot of people that have problems. So now I try to make people take them if they think they need them. Take it, you know, they'll give us more. Take it home. If you need it, you got it. So it's definitely something I think should be everywhere.
More targeting the business owners to try to earlier on when we.
My name is Dr. Tisha Smith. I'm the Director of Addiction Services for Monroe County. Our community continues to experience overdoses and we're losing lives. The use of fentanyl, counterfeit painkillers, benzodiazepines, heroin, cocaine, and methamphetamines all increase the risk of an overdose. Naloxone, given as a nasal spray, can reverse overdose and save lives. It's free and available throughout our county. Simply peel, place, press, save a life.
Yeah.
New York State now wants to use American law to protect individuals from arrest. They call 911 for themselves or others who may be experiencing an overdose. If you suspect an overdose, don't wait. Call 911 to save a life.
Hello, because they're afraid.
I'm Dr. Maria Elena Velez de Brown, the Commissioner of the Monroe County Department of Public Health. The opioid epidemic is a national crisis, and Rochester is no exception. In 2023, the Medical Examiner's Office reported 512 fatal overdoses, many involving a combination of fentanyl and cocaine. If you are using drugs, there are steps you can take to reduce your risk. Test your drugs for fentanyl, never use alone, and carry naloxone. Together, we can save lives.
Ending the opioid overdose crisis requires all of us to take action. Small efforts like educating your family, friends, and community members about substance use disorders can help save lives. Stop the stigma. Start the conversation today. For more information or for more treatment options, call 585-753-5300. Help save lives. Carry naloxone. Learn how to use it.
When I first considered to stop drinking, I had this notion that everyone had to go into a rehab facility. And I was fearful of that. And what I found is I didn't have to. I could follow my own pathway of recovery. I never thought my recovery would mean I'm running marathons or climbing mountains. But that's a huge part of my recovery. A little progress each day adds up to big results. Recovery is possible. Treatment works.
A lot of stigma around that too. The new grief supports, virtual and in person.
How do you get this? Because I saw that on the elevator coming in. I never, like, how do I get this flyer? Are you gonna send it out so we can send it?
Or like a flyer,
Mhm.
yeah, I can
Okay.
make sure that that gets distributed to all of them.
We make naloxone available in the libraries in the city of Rochester because we see what's going on in our community. So if we see somebody who is possibly experiencing an overdose, we don't ask any questions. We get our naloxone, we are not afraid to use it, and we try to help them because naloxone can save lives. Naloxone is free. Get your kit today.
And we can, we don't have to watch all.
Thank you.
of them.
All right.
Then they start to cycle through other chiefs, Spanish speaking officer. I do mine in Spanish. Those are mile a minute because there's a lot more words in Spanish than English. So those and the long form stories of each of the folks in recovery, I think are really impactful. And I don't remember if I shared with you all last month. The last campaign that we put out, the Faces of Recovery, within 30 minutes of that first commercial going out, someone was already calling saying they saw the commercial and they want to get help. So within the first 7 days, there were at least 7 unique individuals who the team connected with and either transported to open access or got to that first step of evaluation. So Tisha is quick to remind that for 2 years, she's been asking to do that one and it's really effective. And so I think something similar to that, using the dual settlement dollars would be useful, and we will certainly be happy to reach out to any and all of you that have youth ambassadors or leaders that are willing to kind of vet some of this information.
The red dots on the map represent.
Locations where we have an naloxone box posted.
So, yeah, I was gonna say, so we've had a lot of success going through our Youth Voice One Vision program, the leadership team. In terms of reaching youth, so we have the Youth Indoor Bill of Rights, we have like the policy task force, so. I can definitely put you in like if you wanna kind of like go through that and what it is, it's like all the leaderships from all the art centers kind of like roll up into this one leadership team that we use for a reason, so. Some suggestions for the funds, I would think would be like, sometimes we try to pay you for their time.
Yes.
Food's always good, so that kind of stuff, but that I would, if you're interested, I can be in contact.
Yes, all of the above. Yes, I want all of your ideas.
There's a youth research group too, that you're probably aware of that, I think Edith runs, I don't know if Edith runs it or Diane Morris, but, made out of youth from the community, also get paid for their time and give some suggestions on what we should be studying or not, so they're great and they're a great resource.
And then your suggestion, sorry.
The youth advisory board, youth and parent, but youth advisory board from Dallas Pediatrics. I would also add, I have youth from North Carolina Coalition. We just had this guy who was a part of the youth vision, Robert. And then have you thought about teen empowerment, because they have a lot of youth, and also Center for Youth, right? They have a lot of couch surfing runaways that are all connected.
Yeah.
So most of the youth come from those different entities.
The schools have their own mind, correct?
That was my understanding.
Yeah.
So other groups that are receiving Jewel funding is, I think City is getting some. I think it's City of Rochester, the Rochester School District specifically, and then BOCES is also getting some, so I don't know the amounts of any of these. So I would be happy to know and connect with any folks that are already getting it, because we don't need to duplicate, we can complement one another's work.
That's Marina was, I had mentioned that.
I emailed her.
Cabinet meeting, yeah, and she said, oh, I've been waiting to hear about that, but I didn't know if she was waiting to hear when you got your money or she was expecting, I don't know.
Yeah, I've reached out, she's at U of R, right?
Well, she's in the, health, community health and prevention, where do I work? She runs the clinical space up there, but she also runs a Jewel, e-cigarette vaping.
It's like the
cessation,
vape
yeah. And they haven't had a lot of success getting youth involved, I mean, getting youth to take the class, so they're trying different models about how they can.
Well, certainly it would be helpful to hear what they tried and failed, so
Yes.
we don't get on that same type of page.
I'm gonna add one more. Dr. Natalie LeBlanc from School of Nursing at U of R. She does a study with youth with risky behaviors. Her and Rose Maharia, who's out of Ohio, however, they partner together to have a lot of youth in the study. So that might be an avenue to reach out to. Yeah.
Thank you.
Yeah.
Just a question, are the funds limited to support just e-cigarette prevention, or is it any nicotine I'm asking about like Zins and pouches, which are.
We have some outstanding questions.
Okay.
I'm hoping to hear responses about like the actual timeline for when we're gonna get the rest of the funds. And we too have, I'm hoping for clarification about whether we can spend it on the nicotine pouches, because kids no longer need to vape something. They can just stick this little pouch of nicotine in their cheek. They don't even have to spit. So they're just absorbing it through the oral mucosa or swallowing, and it's kind of gross to my mind, but then it's even harder for teachers or others to identify that kids are using this. But I'm sure it carries all the same risk, and so I don't know that we have answers to those questions.
I don't, I think Brendan would know a little bit more, but I'm writing a note so we can circle back and.
Okay, all right, because I think, the vape settlement funds came after so much harm was done, and I would really hate to have to wait when we know the nicotine pouches is another current problem, to have to wait another 5, who knows how many years to get any funds to combat it. So.
I mean, there's a lot of the same challenge dealing with like all the flavors and stuff, and I know some states have like banned flavoring the pouches like they did with the e-cigarettes and other stuff too. Not for this, but yeah, it's growing.
And the funds are again, supposed to mostly target youth, but education and prevention for residents who are under the age of 21 or who were exposed to ends while under the age of 21. So how do we engage parents in that? Adam Bello is very interested in also connecting with the schools. And so he's interested in doing a similar model when we got COVID money to make that available to schools, where, I don't know, you portion some amount of the funds to different school districts based on their size, and then just offer them, apply for these funds and make a compelling case for whatever it is that they need. He really sees the schools, he considers them to kind of be the front line of the fight against vapes, which I think makes sense because they have a captive youth audience. And so many schools already are doing something, we just don't know. So could we make these funds available to them to shore up what they're doing or expand it or, do something else creative? And then the final plan that we have so far would be to fund a point person in our department to kind of manage all of this. Like, we're going to have an application from schools and pull together the advisory committee and really have a point person for that, because all my staff are already full-time employed, and so we really need more personnel power to really pay attention to this, or it's just gonna go too slowly. But I am very interested to hear other ideas that you all have, or if you've heard what other geographic areas or institutions are doing, because maybe a whole month warning talking about it.
Yeah, it's hard because having this debate with my adolescent child or adolescent, young adult child, the argument of cancer is gone. Argument of, it's constant nicotine, which is a problem, right? And I get it, it's not good for you, but all the typical traditional arguments that work, I get, well, people drink a glass of wine every day. That's the same thing, and
Tell me more. I don't think I understand why you feel that cancer argument is good.
because we're not smoking cigarettes, and also the carcinogens are not in the packs, it's straight nicotine. So,
It's not healthy for you either.
agree, that's not a cancer argument. Saying nicotine in a packet or in a vape is not good for you, I'm not making that argument, but the things that even young people like my son will say, I would never smoke a cigarette, you gotta be an idiot to smoke a cigarette because of all the cancer and all the stuff that's in there. They managed to take all that stuff out. I'm not saying it's good, but the argument of this is gonna kill you is kind of not so strong. And jury's out on nicotine over a long time. I mean, it's not good for you, I'm not saying that, and certainly the burning of fumes with the Juul thing is not good for you, for sure. But I don't know, that's my experience. So you got, what's the thing that's gonna grab them this time,
They can sneak a vape, they can sneak a cigarette,
Right, it's not restrictive at all, you can do it, yeah.
So this doesn't cause oral cancers like chew or?
I think there hasn't been enough time
Correct.
to get that research. But there are things like propylene glycol is in vaping,
In the vape,
the
right.
popcorn lung incidents.
Absolutely.
Sound back, so that's pretty scary. It's cancer scary, but you can use that.
Yeah, well, no, because we've moved on to the Zins and I run out of arguments on that, like, whatever.
The Swedish stuff was supposed to be really like natural and
Yeah.
not bad for you, and that there is research on that.
Mm.
And that does lead to cancer, so you can possibly go that angle.
Yeah, I know of it, yeah.
I mean, absolutely.
Yeah.
I mean, with your patients,
Patients,
I presume.
I frankly don't even really touch it because
Dealing with
I'm
other things.
dealing with other
Yeah.
things. But at home with my own, adults.
Yeah.
They're kind of on and off and in and out, but it is. The vaping felt easy to me because you're inhaling God knows what.
Yeah,
into
into your
your lungs,
lungs,
and that's
yeah.
just.
Yeah.
But these Zins are
Even hard.
they're like the answer to all of the reasons not to do it.
Yeah.
So I think part of it is why not?
Are they like kind of like the equivalent of, nicotine lozenges?
Yeah.
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 And certainly any abnormal substance is not a good thing to put in your
Right,
body for sure. But why do we drink alcohol? Why do, you know, be it so, I mean, why do you drink caffeine every morning? It's the same thing, Mom, you know? Yeah, I'm like, I'm out of, I can't.
You're right.
I'm done.
Caffeine.
Right, exactly. That's not good either, but it's a harder sell and it's a harder campaign and it's a hard, and I don't know, you know, these youth groups maybe have the thing that's gonna stop people from doing it. But it's not the health issues anymore, I don't think, and I don't know what it is.
I think there's some evidence of like receding gum lines and tooth issues that result from it, at least in the short term, what we have now, but I agree, it's harder to make the argument against nicotine.
Yeah.
I always ask my kid, you know, I ask like, well, what are you looking for? What do you think you need? What are you missing that you feel like you've got to
Turning to this.
do this,
Yeah,
right?
right.
Have that discussions.
Because that's what's going on in the back of my head, like, do we not fight the stop using the vapes and the pouches and start attacking what are some healthy ways to manage your stress and to feel like part of the group and included that aren't going to 20 years from now find out that it was bad for you.
Sure.
That's what I was thinking of lines of psychoeducation, because that's always what I'm interested in, even though you're forming the forums, getting the education out, I think is more important, but also the need to find healthy supports for them, healthy support systems, specifically for youth, right?
Yeah.
Because if I'm attached to someone, if I'm doing things because of a response, I'm going to more likely resonate to the folks who are doing unhealthy things because it's going to make me feel better, versus me necessarily taking the time to kind of understand what a healthy support system is. So if I come from a trauma family that has a lot of things going on, I've seen this, and I don't necessarily have a positive person in my life who can even show me what this would look like, then for me, I'm gonna resort to that. And no matter what you say, this is what I'm gonna do until I get somebody healthy that can help offset that. I don't know if I necessarily feel the right word,
that makes sense.
just trying to figure out like education and the way that it deals with support. So if you do focus groups, not just focusing on this is why you need to stop to that point, but focus on, okay, what does this look like? We can talk about some of the barriers, but how do you even identify? Because a lot of people don't know how to identify what a support is. Like that you can ask them what a support. I don't know, I've never seen it. I'm not used to it. This is all I know. So you telling me this doesn't mean anything. But then finding a neutral ground that you can say, okay, here are some positive things that other folks have done and share stories to your point of your videos might be healthy and realistic, specifically to our youth.
Yeah, the video campaign, if you got youth that quit, why they quit and what they, you know, it's just
And what are they doing
instead, yeah, exactly.
And I also think it would be, I haven't looked, but in the survey data, when are kids starting? In what context are they starting? Is it the same as cigarettes and alcohol? I mean, I don't know. I feel like it's more, has been. I think there's fewer vaping than there once was because of Zens maybe.
Yeah.
But then it's also more kind of has been more kind of acceptable among athletes, like just among groups of kids who maybe weren't the big cigarette album. Yeah. So I wonder if it's the same initiation process or something.
These are great questions.
We will hire somebody to do that research and find out.
You got $860,000 to play with.
Other ideas, other thoughts, other things you've heard, other places, other.
I'm trying to volunteer some people come and grab it.
Trying to figure out who it is.
It was during COVID, they got a group of young adults together that were dealing with issues related to mental health and isolation. And anyway, this was really interesting. They got together, did a comic book together and poetry and all sorts of stuff. And
That's ringing a bell.
It was a
Yeah.
precursor to like the fifth ACE.
Yeah, it's work that we did.
Yeah, it was the precursor to that, I think is what you're talking about.
And we still are engaged with those folks, so if that's a group to test things with, I'm sure they'd be open to have a conversation. Yeah. Dina Fatima would be the right for that.
She'll hold the collective that. You said there were 4 options in the jewel space. Did you give us 2 or did I just? You said you were debating between 4 options.
Oh, no, these were things we kind of had sort of offered and that the county executive seemed willing to accept. So the county response, updating signage and, you know,
Yeah,
they ban smoke free, the media campaign,
right.
putting out kind of not like free for all day, but like sort of grant application type of funding for schools and funding another staff person to manage all of this.
Gotcha.
But we're open to other ideas as well. Because eventually there'll be $2.2 million at some point, which we'll figure out. So I feel like that could be a lot of good work. Stuff like that. Yeah. And I'm sure we'll get more ideas that I will be happy to present to you when we speak to the academics and to, you know, our school colleagues and others.
Yeah.
So thinking, see that's interesting, send it along. Open to suggestions.
Good work.
I unfortunately am not really prepared today to talk about the anti-violence work. It's just been.
Yeah, that's okay. I mean, I wanted, if it's okay, can we take a minute? Just, I was so happy to see in the news so much last week or the week before about how gun violence across the board is getting better, significantly better, it seems like. And then I thought, well, I should do a public house grand rounds about this. And then I said, oh, wait, we already did. We had, thank you, from RIT. And I'm like, oh, wait, I think it's his group that's doing the.
You have the press conference from the city? Huh? Is that where they?
Yeah, from the city and the police department. So is this a real thing?
They
Is
do
that?
that, they did that every quarter.
Yeah, I mean, I know I've seen, but they seemed,
They do a big one at the beginning of the year, but they do it.
it seemed like where things were real bad for a couple of years, they're definitely, it seems like we made a turn. And I
So I
wondered what
can
we're
tell you,
accounting
like-
that to, and yeah, it's real. Yeah.
Yeah, so it is real, like our FE team, and I just didn't have a chance to put it all in a pretty package for you all, but the epidemiology team did do an analysis of homicide incident reports, shooting incidents, and part 1 crime index data sets. I don't know what part 1 crime is, I'm sorry.
Those are like the major crimes.
Okay.
Yeah.
That. From the RPD open data portal, focusing on homicide and non-fatal shootings. And the data from 2021 to 2025 just go down.
Yeah.
From 147 homicide incidents to 59 incidents in 2025.
That's what I'm saying. I'm
So the
like,
trend is.
so this is good.
Yeah.
It's non-fatal shootings down from 419 to 162 and skimming here, fallen below pre-COVID levels for reported incidents. So that's.
The big.
Yeah, I think that's why it's hard. I didn't watch the press conference, but I've been a part of them again.
Yeah.
So I think it's just hard to say like this is the thing that has happened. It could be COVID, right? It could be all the different efforts the city's doing. It could be a bunch of different things. And so I don't think that. Again, I didn't watch the press conference, so please take it with a grain of salt. Maybe Miguel did. But it's hard to say exactly what is the thing.
Well, it sure is nice that it's a thing.
Yeah, yes, yeah. And I know that
Was saying he's not gonna remove the emergency thing.
Yeah.
That seems to be part of it or having some sort of effect. And
yeah, that's what he always says.
So
There's a gun violence emergency order that's been basically on day 1. He's in office.
Yeah.
He keeps doing it every month, I think. Yeah.
Oh, it has to every month.
I think there's a sign off on it every month. But yeah, he's been able to do some of the things that he's been able to do, like close down businesses that are problems and things like that, the emergency order. But yeah, I mean, I think that he always talks about how he's not gonna like just let off the gas because the numbers are down. Like one homicide is many. So
Has there been a compare and contrast with summer versus winter?
always,
It's always higher in the.
always higher in the summer.
And so those numbers impact the whole summer, in the winter.
It's the calendar year.
Yeah, so the data that I showed you that I will have for you next meeting, is the entire year.
Okay. And I imagine your shot is. Same number? Her shot is seeing the same thing or following the same data that's coming from the city. I don't know that.
Yes, multiple sources. I mean, I was thinking who was the expert, so.
Yeah, that's right. I'm like, who would know that? And then
Well, I mean,
you're gonna have
the-
the police chief come, she's like,
Right, it's like, I mean, if you want someone from RPD to come, I can certainly set that up, that's not a problem at all, but I would say that he's the academic expert, I wouldn't say that he's like, you know,
yeah, of course.
End all be all expert, I would say.
Yes, yeah, just an expert.
Yeah.
Maybe the two together, but I also wanted to, and then I thought, well, the counties, this would be a great opportunity to talk more about their violence and the university is doing a emergency room safety violence prevention project as well. So I think there's a lot, obviously, you know, there's a lot of different projects going on. So maybe it's making a difference. I don't know. We can hope.
I mean, I think those press conferences involve like 3 different departments that present, 3 different departments, so I think like that's why it's hard to say like this is the thing that is.
Yeah.
I love to hear about the prevention.
Yeah.
What have you done before?
Yeah. Back to the mental health questions and, you know, yeah. Where's your support system?
It would be cool to hear from them again. I want to hear Snug and all this other.
Maybe next.
Yes.
In
So next.
conjunction with your.
I don't know, the schedule, Celia did that schedule.
And she hasn't let me know. Albert knows, he's like, wasn't I presenting tonight? I'm like, Celia? I need to see that list.
You want me to chime in?
Yeah, I looked.
Oh, I heard her. Celia said something.
What did you need me to chime in on? Sorry.
We're laughing at when you were in charge, you set speakers for the remainder of the year, but I want to make sure I'm reaching out to those folks. So if you have a list, send it to me if you would.
Okay, I'll have to create one.
Oh. Thanks. I mean,
Yeah, I think I only had them up till April.
Okay,
April, all
all right, so I may have exaggerated to you.
That's still 2 months that I have unaccounted for, so.
Yeah, I'll take a look at the.
I don't know. The door might help, I'm not sure.
I think it was a personal summer.
No. But if you want to talk about violence prevention, I only threw that out there because I was like, oh, that's great, we should be hearing more about the good things.
Sorry.
Poverty too is heading sort of in the right direction, I mean, it's good we talk about the positives. So if you are planning to talk about good violence, we could certainly invite Sean and see if he is.
I would love to hear about poverty.
Yeah, I mean, for sure.
I'm
Yeah, and Martha Harshaw. It's her community engagement person.
Oh, okay.
Well, if you want anyone from the city, you certainly make connections. Thank you.
Well, is the mayor still doing the guaranteed income project?
No, that was not them.
So
There was a report that came out that talked about how successful it was, but I've not been a part of a conversation where they are thinking about continuing yet.
however, I think the GBI money that's going to Healthy Baby Network to fund the NEST program is coming from the city, is it not?
It's coming from the state. The state gave us 25. Okay. It's a lot of money, millions of dollars to combat poverty in Rochester. The money's flowing through DHS and we're working closely with DHS, but that was one of the projects from like 25 million.
That's great.
Yeah,
Are there other projects?
I think there was like 2 or 3 other projects, but I don't know.
Where would we find those projects?
So DHS is the
Like on the website?
Oh, no, they're not, that's the
Yeah.
one that's been announced. I don't know what the conversations are. Gotcha, they're not part of it.
Because we did advertise for that NEST program, which is
Yeah.
giving GBI to pregnant
Right, I
women
forgot about that.
who are working on.
And it's
After
right,
pregnancy, right? I think it's about 2 years after.
I think so, yeah. And that seems
So
like.
those who are new to this, GBI guaranteed basic income.
But maybe she'll read it. I'd like to volunteer people since I.
Yeah, Jackie presented at the MCHHE meeting.
On
On
the
the
baby
NEST
network,
program.
Jackie?
Yes,
Oh.
I know, there's a lot of junkies, aren't there? Yeah, and she did a great job, talking about where they're at now, they're still accepting applications, they're not full yet, and what else involved in the process.
Send me some, I sent it out at that time, then I forgot about it.
Yeah,
I think we just, every now and then. we-
It was like for certain, I think it was certain, I don't say zip codes, but maybe.
It is.
It is.
Yeah, it was like certain areas, yeah.
there were about 5 or 6, I wanna say.
Okay.
Yes.
Okay.
It wasn't every zip code in the city though.
I can send you her PowerPoint.
Those my zip codes, but I felt like it was concentrated in the Northeast, but you're right, my office was 14608.
Now, I don't know if that GBI program is an extension of the one that went through the church last year. Was that like a next iteration of that? The woman that we had talk at our public health grand rounds, who I can't remember her name. There was a guarantee based income project that Notre Dame did the evaluation for.
That's the one with the city.
That,
Oh,
so,
it's Christie.
yes, see? Yeah, I didn't know if this was a second iteration of that idea, because she had talked about. The woman in charge at Corpus Christi was talking about, the next iteration should be just for pregnant women or new families.
Yeah, I mean, I think that our Mappy for a while was on like the single female head of households, like kind of targeting that group.
Yeah.
And so maybe that's where it came from, but I don't know. But I wasn't.
A good fodder for future meetings.
I would love to hear more about
GBI, poverty.
all of the social determinants, but starting with poverty, it's a big.
And then perhaps violence. March people.
Oh, never.
Yeah, well, exactly. Once we figure out, once I reread all the notes, yes. Sorry.
So that was my report today. Short, not so short because it's rich conversation.
Yeah, for sure. Yeah, thank you. It's good. Good work for sure, and necessary, so, and those videos are awesome. Yeah. Right, I don't know who shot them, but they're good. They're good, yeah. And you said they're moving in the DHS waiting rooms?
Mhm. So downstairs, when you all come in the employee entrance, but if you come in the public entrance, there's screens, and so it'll be there at 691 St. Paul Street, which is the other DHS location, and we can think about other places to share them because it I think they're quite.
St. Joe's, I mean, there's, yeah.
Yeah, right. And Ms. Branford.
Yeah.
And our,
Ash, Warren Gordon, right. All right, I guess that moves us along to the president's report, which, love to hear from Albert. Since he got punted last meeting for the Hero Project, so now that I know, so, the floor is yours. 45 minutes.
Thank you so much.
Where's next? Next, please.
Sorry, not to.
No, you're good. So I want everybody to be all satisfied going.
Super transition.
And I actually think like the timing works out really well. In December, you guys got to hear from the SEN, the Social Care Network, FLIPA, which is the first leg of the waivers tool. Then we heard from Carol Tagus last month, which is the workforce investment work, which is the second leg of the waivers tool. And then I'll talk a little bit about the Hero work, which is the third leg of the Medicaid waivers tool. As it's set up, so happy to share. I think I have to flip my badge around so that I'm talking as a representative of Common Ground. But really happy to share kind of the stuff that we're working on, really more from a bigger picture perspective as it relates to the waiver and talking about how do we demonstrate that the things that I think a lot of folks had a long standing understanding of in terms of social determinants of health drive health outcomes, and if we're supporting those, we have the opportunity to improve health outcomes. That's really the crux of what this waiver is aiming to do, and part of our role with that is to help get us to be able to demonstrate that. So I title this slide "Holding Out for a Hero" because it's a lyric that goes back a long ways for me. And it's been a long time since we've been talking about this. So back in August of 2021, Common Ground Health was cited as a sustainable model for a health equity regional organization, HERO. Citing that we are a nonprofit planning research organization that provides ongoing value to the community by bringing together stakeholders on area health issues. Speaking to the idea of, what we do is try and ground our work in both the data analysis that we're able to either collect or identify, rooting that and testing that with community, and identifying and implementing solutions to drive community health impacts. Back in 2021, the state saw this as they were developing their waiver proposal for the state and saying, we need regional work like that happening to support the idea of this waiver really being able to have positive impacts that we can demonstrate on health outcomes by addressing social determinants of health in the Medicaid population. I won't go through this diagram piece by piece. This was the original concept, is that every region would have a health equity regional organization. They would be working with the State Department of Health, as well as at the time they weren't called social care networks, they were called social determinant of health networks. The qualified entities, meaning the regional health information organizations in their region, providers, MCOs, et cetera, to really help drive the thinking around how do we enter into agreements that are going to facilitate making these improvements and reducing costs, et cetera, for the Medicaid population. Well, in conversations with the feds, that evolved significantly, and they kept the name Health Equity Regional Organization, but made it a statewide organization. So there is a statewide HERO that the United Hospital Fund is playing the role of across the state. However, Common Ground Health has entered into a partnership with United Hospital Fund, where we are doing the direct work in a 14-county region for the Finger Lakes, as well as providing statewide support for this effort. So we are providing our data statewide, we are providing coaching and support for United Hospital Fund statewide. For folks that don't know, they're a nonprofit, primarily focused in New York City, don't have a ton of upstate experience. And so we're essentially their upstate arm, helping them be able to do all that. I do want to flag that in the model, we got public health and the prevention agenda to be included as a stakeholder in this work, recognizing that that was a gap. Also, an increased focus on healthy childhood development, integrating mental health and primary care, and identification of workforce gaps. So that was how it evolved between 2021 and 2025. When this really got kicked off last year. We've been really happy to partner with the United Hospital Fund and help them work through this at the state level, as well as help to guide our partners here in the Finger Lakes region. Yes, Dr. Clark.
If Common Ground Health was the example of an organization to be here, why isn't Common Ground Health here like that?
The state, I think, really wanted to go, because it is a massive effort statewide. They wanted to go with an organization that was a bit larger than Common Ground Health, and the United Hospital Fund is a significantly higher or larger organization in terms of just revenue and capacity and staff. And so,
But not with a statewide presence.
Not with a statewide presence.
Not the Common Ground, I said we, that was coming soon. Okay.
Yeah.
All right.
But statewide, this is really the role of the HERO, and it's $125 million that winds up getting over 3 years. Through March of 2027, with the role of doing data aggregation, which we're providing a lot of support on, as well as building a regional needs assessment and planning. This has been a bit of a tricky piece to navigate, as we all know that the public health departments for every county, as well as the hospitals in all of our counties, do regional needs assessments on a ongoing basis, and This is, you know, obviously more focused on the needs of the Medicaid population, but is a, you know, another look at the needs assessment. And we've been working through how do we make this a value add beyond the current infrastructure and doing that. The goal of that is to use that needs assessment and planning work to help create value-based payment design and development for health-related social needs, which is also the social determinants of health. You know, the language always keeps shifting on this, but in this program, the language that we use is health-related social needs. And really the goal of this is to say at the end of this demonstration project that it is worth it to enter into value-based payment agreements with community-based organizations, with folks providing support for social determinants of health, health-related social needs, that it makes sense for the managed care organizations, the insurers, to be able to enter into these agreements to provide that support because it improves outcomes and results in lower costs across their Medicaid populations. And lastly is program evaluation, which, you know, really supports that VBP design and development, as well as how are we doing? How can we make improvements? What's working really well? What's not working so great? How can we support that going forward? And so that's the role and the work statewide. And just to try and consolidate that into two key statements, in 25 and 26, the goal is to produce this regional needs assessment that supports social care network decision making around supporting the health related social needs and prioritizing the chronic conditions that allow for payment for these services inside the waiver program. Patty talked a lot about this when she was here with us. And supports the department's request for an extension of this program going forward. I will just share that it's not clear, you know, what the viability of a no-cost extension is in the current environment. But we do believe that the department is going to make some sort of a request to continue this work and leverage unused funds to be able to demonstrate that impact. And then, as I said, in 26 and 27, using that needs assessment and all of our learnings to create a regionally focused value-based payment model that can be adopted with the social care network, with the managed care organizations, with the State Department of Health for both Medicaid and this is maybe me being a little Pollyannish, but in other populations as well, right? We know certainly that folks that are uninsured or underinsured have these needs as well as commercial and Medicare members, right? These needs are not just in the Medicaid population. So if we can demonstrate value here, my hope at least is that we'd be able to demonstrate value for a lot of those populations.
When you say regional,
yeah,
is it the same region as the social care network?
It is.
Okay.
Yes.
What I was gonna ask, so you're for the region, the Finger Lakes region that flips and
Our 14 county, well, for FLIPA, so with FLIPA, yes, it's the same region.
Okay.
For FLIPS, their workforce stuff is from Cayuga County all the way west.
Yeah.
They have a larger footprint for the WEDO work. And you know, I have found in my engagements that, you know, how we define Finger Lakes varies significantly moment by moment, depending on the needs of, you know, whatever we're talking about. But yeah, we line up with the same region. Yeah.
I hope that the different community health needs assessments that choose the chips of the various counties that are included in your region are brought together to inform that needs.
And they absolutely were. Actually, that was UHF's first step. Was to leverage at the time, so this was back in 24 before the most recent ones were done.
Yeah.
They took the most recent CHIPCHAs from all the counties and did some synthesis of that as a starting point for the regional conversation. We have now pushed to say, hey, we got a whole bunch of new ones
much better ones too.
That you know, also should be included as we work on that needs assessment, which is at the moment due in June of 2026. So, but yeah, we've been saying, hey, we should probably take a look back at that and say, hey, there's a bunch of new ones in CHIPCHA perspective. Absolutely. Of course, this is just a little bit of detail about what the regional needs assessment includes, the outline of it. I will say this is a little bit of a moving target. We keep, you know, revising some of the specifics underneath this, but it helps if I advance the slide. You know, the needs assessment structure is, you know, introduction, obviously executive summary, some community descriptors, the health and social care landscape, so looking at the supply and the demand for SDOH needs, HRSN needs, right? What are we seeing in terms of need in our region and below sub areas of our region and specific populations? And what are the assets that we have at our disposal that we can actually leverage to do that? And I will say that as the work is getting more and more maturity, we are learning a lot more about where those bottlenecks are starting to show up in housing, in food, in all of those spaces and what that means. And now we're sort of talking about okay, well, how do you make sure that when you make a referral for housing support, a specific kind of housing support, that asset is available in the community and we have the capacity to meet that need for that referral. And that's the ongoing conversation and dynamic with everybody that is participating in this work, is figuring out how do we move that forward and get the resources there to build those where we don't have them, as we are demonstrating the need for them with the screenings and referrals that are being done.
I think government is here.
Government's a gap.
I mean, the fact that we're not involved at all is a huge gap, right?
Yep.
I mean, I've spent pretty much all weekend trying to get this one person into housing. That's only because, and the only group that was able to kind of work with her all weekend was picked because we're 24/7. And we're not connected to the social care network at all, so because of money.
Yeah.
So I do think that's just from my little weekend. Yeah.
And there are so that's good feedback. And I'll talk about some of the work that we're doing to get that feedback, but there's also prohibitions about local government units being able to engage in the waiver.
That's what I'm saying.
From the state.
That's what I'm saying.
Yeah.
That's, I mean, I think we've talked about this before,
Yeah.
Because again, there's not, these organizations aren't 24/7 and these crises aren't 9 to 5, so.
Yeah.
Medicaid person?
Right, if it's pending, or I forget what the resolution was on that, but yes, there is a lot.
It's complicated. Yeah, and so then just the methodologies, I'll talk a little bit more about the stakeholder and community feedback, and we're gonna do that. And on the right is just a list of the data sets that we're using to inform this. So Sparks is hospitalization data. We have a multi-payer claims database that we utilize. There are mortality statistics. We don't have access to the birth vital stats, but we have access to the mortality vital stats. Leveraging BRFSS and YBRFSS where appropriate. Others, we're also leaning on the Rochester Rios data infrastructure and trying to see if there's information we can do from that. We're doing a little bit of primary research, and then we are leaning on the SCN and UHF. Part of how this is structured with the state is all of the screening data that's being done as part of this statewide is flowing into the waiver, and the United Hospital Fund has access to some analytics based on that data. So we have some insights as those screenings start to ramp up and get more, we get more folks screened to be able to have a better understanding of that.
Because you're the Rio, other, there's no addition, you can just get it, right? You know.
You're hurt. Right, Dr. Clark, you listen, just snap your fingers and go. No, we're working through what that is and how that works with the Rio's infrastructure and requirements about what they're allowed to disclose. But obviously we would not be disclosing anything remotely close to identifiable information as we work to do that. It's at the population level, at a county level, a zip code level, those types of things to be able to build that out. But just navigating all those requirements, as I serve as the compliance officer now for the Rio, it is a tangled web, more so than I was even used to at Common Ground. This is just an example of some of the things that we've provided statewide. It is BRFSS data, hospitalization data, mortality data that we have made available to organizations like ours that are doing this work in other regions across the state. So we've built a lot of dashboards, a lot of availability to look at various data sets that we have access to statewide that they can leverage for the work that they're trying to do as well.
I'm sorry.
No, it's
I'm not
okay.
asking my question.
No, you're good.
If 1 out of 8 people are served by community health centers in the state, why aren't you using community health data? Like UDS data?
It's never been patched or never been.
Oh, it's free. I mean, it's the. I know I'm feeling sensitive because February 15th is our due date for turning in all the data, as every community health center has to.
Yeah.
FQHC lookalikes, everybody's got to turn in the same data.
And you said there's a database
public.
that's public?
It's public.
Do you know what
Never
that
heard
is,
so.
what it's called, or just?
I just like, even if I wanna look at mine, I just say UDS and then whatever health center.
UDS?
And it's, you know, CVS, not CVS, but CSV file format.
Yeah.
We'll look into it.
Yeah.
Yeah, absolutely. Thank you.
But I also offered the ACS from the Census Bureau community survey.
Yeah.
We are leveraging, I didn't list it up there, but we use the ACS data pretty robustly as part of this they do ask a lot of those questions, and on the 3 and 5 year estimates, you can get some level of granular in terms of what people need. Yeah.
Can I ask a data question?
Of course.
I already asked Lucas, but I'm gonna ask you now.
Please.
The social, if we're looking for information on social drivers such as food and housing, and some health systems, the two big ones in Monroe County are
Yeah.
screening for that.
Yeah.
Assumedly, that data is in the Rio from those entities that screened. So can we not get information about food insecurity, housing insecurity from that information in Rio?
So the short answer is yes.
Mhm.
The long answer is the state has put a lot of limitations about what we're allowed to use for this. They only want the screening data funded by the waiver, which right now is
Well,
not being
forget it.
executed
Yeah,
at the
absolutely
hospital
not.
systems and done that
Yeah.
to be the driving data set. So yeah, understood. But that is the barrier to being able to leverage that data for this purpose.
Yeah.
Does that data go into, if I, you know, have to.
It's in the EMR, yes.
Everything. goes
Now,
back-
not everybody is screening and not if the narrative things, but if there's a discrete data set in the EMR. That gets shipped into Rio, my understanding.
If it's not, it can be.
Yeah.
But my understanding is that Epic allows for that to be transmitted as a separate file. I'm not confident that it occurs consistently across all of the hospitals inside both hospital systems at this point in time.
Well, they have their, I mean, the other thing is you guys made your own, right? You-
No, we screen in Epic, and so
Right,
all of
but
that.
it's,
But they're
but
using
it's,
Promise, right? Or they're using the.
I can't
Not for
remember,
the-
but my understanding was they made their own changes that worked well for U of R.
No, we're not in the social care network either. We're not.
Right, they're not using that
network.
at all, but I'm just
Yeah.
saying the, like, for instance, we use Prepare. And ours, you guys use something that looks a little like Prepare, but it's not Prepare. I'm just saying, everybody's
There
not
is a
speaking the
promise
same
tool that some
language.
people use, but
Mhm.
as an institution, we are screening with Epic tool. The Epic wheel and 10 questions on different social needs. And all of that is in the EMR as a discrete field, just like the blood pressure. And all of that should be, as your EMR is transported into the Rio. My understanding is Rochester Regional is doing the same. Now, that's the reason we're not in the social care network is because we don't want to create this random other system, right? Now, certain departments maybe, and ortho definitely got excited about Promise and hate that tool so much, but some people love it and they're using it all the time for research questions and such. And that probably wouldn't be uploaded, I wouldn't think it's EMR, but the standard EMR record probably should be.
Yeah, yeah.
That's
and-
interesting.
And admittedly, Teresa, I haven't pursued it because we were told.
Yeah,
can't
no,
do
no,
it.
no, I totally get that, yeah.
Yeah,
Wow, okay, thank you.
So as someone who doesn't work for a hospital system or in
Yeah.
healthcare, are you looking at non-health data sources?
what do you mean by
So-
non-health data sources?
So like 211.
Oh, yes,
Yeah.
absolutely. We actually, we entered into a contract with them in December. They're gonna
Okay.
give us a dump of both. All of their, the various organizations that they have in their directory, as well as some call records in terms of what people are asking.
I was gonna say they have that
Yes.
dashboard
Yeah,
that
they
says
do.
like the call needs, I mean, I'm like steeped into the homelessness world now. They have their own kind of federally regulated database too, which is very hard to break into. I'm just saying, I'm just wondering. I mean,
She's not trying to.
I'm not trying to break into it. I just, but we know what you know. What you know. You know what I mean? But I'm just wondering like if there's sort of like non-health, because those assessments are great if you're going to the doctor, right? So.
Oh, for sure, and we have the population health data, in fact, Common Ground Health just put a whole bunch
Yeah.
of it on their website, which is great, using the neighborhood survey information and bureau, you know, all the non-health stuff. 211 is a great thing that's probably not.
But the homeless ones that are HRSA funded are also submitting their the UDS data, so.
So that might be.
That might be another, that might be your other way.
Yeah.
I'm just curious.
No, that is
I
a
think
great
there's
question.
other folks collecting information that's not healthcare.
Yeah, and we try and leverage it as much as we can. We have challenges with regards to what the state is saying, like, do the needs assessments have to be uniform across all the regions? Because we have access to a multi-payer claims database that not every region is gonna have. The 211 data we have is 6 counties, not 14. And so like, that is the dance that we do is, you know, how can we demonstrate that with that? And, you know, the 211 data isn't centralized statewide either, because they all operate independently and work through that with their association. But to the point actually that you all jumped into before I brought up the slide, this is actually how the screening data is currently being processed. The waiver screening data that's being done by the organizations that are engaged with the waiver, which we just noted does not include the 2 major hospital systems by and large at this point in time. So, you know, if somebody begins their 1115 waiver journey, this is something I took from the state, to be clear. By receiving the screening at a facility, social care network and others, receive the screening, perform an assessment or a referral. That data does flow through the RIOs statewide. It winds up in what they call the data lake, which is the State Health Information Network of New York, is what SHINY stands for. And then it's aggregated to that centralized repository that can be queried, and you know, you can do population health studies and efforts of that against that. And then obviously it has to go back to CMS for reporting as well. So that's the process to get as much quantitative data as we can have about what the needs are in our region. That is, you know, admittedly, screenings have lagged in terms of what being able to get the volume that we want to see. But this is the goal, is to be able to demonstrate demand via these screenings and referrals, as well as obviously make those referrals and get folks connected to resources as much as we can. So in order to support all of this, we are hosting a series of regional convenings to help provide insight into this. And actually, we had our first convening back in September on chronic conditions and HRS and priorities. The second convening was supposed to be in January. It then got postponed, and now we can take workforce out of the agenda for that. It is really going to be focused on CBO capacity, particularly with regards to the waiver and process improvements and what people are seeing going forward. So since I pulled these slides together, that has shifted in the last 2 weeks, and that'll be in March. And then later, late spring, probably early summer, we'll be having a third convening to pull all of this together, talk about a regional community needs assessment finalization. We are supporting obviously the agenda development approaches convenings that are all subject to DOH approval. So DOH is really holding tight to the wheel when it comes to a lot of this stuff. And we are working with UHF to put our best foot forward in terms of what we think is going to be a successful approach to each one of these pieces, so that we can integrate that input into the regional needs assessment and make these findings valuable for developing a plan going forward. That hopefully will create longevity for this, with or without another Medicaid waiver to support it.
Who participates in the convenings?
Well, this is a picture of it, so you know, pick out who you want. But there were a lot. We invite the CBOs, the FQs, the hospital systems, the insurers. We also did invite the public health departments and others from around the 14 county region to participate. We did this down in Geneva. We'll be back down in Geneva for the March meeting, and you know, hope to continue that conversation there. This is old data now, but I will tell you, I don't have new data to share. But this is the screening data through August of 25 with where the highest needs are flagged. Obviously, folks could have reported more than one need or could have been screen positive for more than one need, but you'll see the housing and food top the list with transportation following up. This was a survey that was done by UHF ahead of the meeting in terms of what the top 5 physical behavioral health needs were. Admittedly, I think we were lacking in terms of results on this, but none of these should be surprising. I don't think to anybody here. In terms of when we ask what the top 5 physical behavioral health needs are across the region, mental health conditions, chronic conditions, diabetes and hypertension, substance use, heart disease. And from the health related social needs, again, housing, food, transportation lined up pretty strongly. So we are seeing the priorities continue to at least align as we go through this. I talked a little bit about this. The convening 2 was pushed to March. And it really is not going to be so focused on workforce analysis. It's going to be more on how do we continue to make improvements to the waiver implementation itself? How do we ensure that we have the capacity to meet the needs of the referrals that we're making? I think one of the challenges that we are hearing as we are engaging with stakeholders and providers across this is not an unfamiliar challenge, at least in my time in the healthcare space, is don't like to make referrals when we know there's no capacity there. Don't like to screen for things when we know that there's no capacity there, because it's not a good feeling to screen somebody positive for something and say, and I have nothing to give you. Yeah.
I'll Sarah Fletcher. She can do it.
Well, I do think I understand it's the 14 county region. Obviously, I'm just focused on the city, so ignoring all that. I do think that government, we do get like a 360 view sometimes of how things are going and where the gaps are. So just putting that out there as like maybe you want. I know you said you invited the health department, and we're not the health department, but just to put that out there.
I think I don't know who it was. I think we invited somebody from the city.
Did you?
I will have to look. I don't know, but I'll follow up and we can.
Who showed up from U of R? Like big U of R, like Kathy and Mike?
No.
No.
It wasn't.
It's not Mike Leary, but he's the wrong Mike.
The only thing I think AHP was there, but I cannot recall who from. I think LJ was there, but I cannot recall who from the university was at the table.
Just curious if you went with president or if you went.
No, we were looking for somebody with more in-depth understanding, and admittedly at the time, the hospital systems were not too eager to engage either. So, but I off the top of my head, going back to September, I can't remember Teresa. But yeah, I can tell you who it was.
I'm sorry, did you have a question?
You did, but
there was somebody there. I remember, and Patty was there, and the SEN was obviously invited and part of the conversation as well. And yeah, there's a lot of overlap with the SEN board, and Michelle Foster was there, a couple other folks. So, and we are actively relooking at the attendee list and invites for the March meeting, because with the shift in topic, we want to revisit that and figure out how it is. And we were really proud of the fact we actually had about a dozen Medicaid members there as well to support it, which is something that we very much believe in common ground. Is you can't have these conversations without the impact of people at the table. And so there was somebody with lived experience at almost every table. And we also gave them additional support. I'm talking about the slide I'm on. We also gave them additional support before and after to prep them for the meeting, to make sure that they knew what they were walking into, make sure, and then debrief with them after the fact as well. And then we'll do the same process ahead of time so that they feel like they are empowered to be in the room and have their voices heard. We talked about the waiver extension request. to a point we've been making on the screen and stuff, quantitative data is going to be limited statewide. So I actually have our director of research out right now talking with folks to get stories of where folks have had positive impacts based on this waiver, you know, looking for the story of I was struggling managing whatever it was. I didn't have, you know, consistent housing. We worked through that with the SEN, got that. I'm now in the ED. It's down from 5 times a month to once last month, right? We're looking for those stories, looking for the demonstration of impact because we're not going to have the quantitative data to be able to demonstrate that. And so we're working on being able to build up that a little bit more than anecdotal evidence that this is working. And we're working on process improvements. With you know, we are actively interviewing folks that are both engaged with the waiver and those that are not engaged with the waiver to understand for the former how things are going, what's working well, where are the challenges, and to understand for the latter what is keeping you out of it and what would help to adjust your thinking about whether or not it makes sense to participate here. I guess there's also just additional challenges with the on-platform screenings with regards to doing them right actively in the SEN app versus off-platform screenings and getting those in and the referrals consolidated and all of that. With that, I won't go into the technical details there. And we really do view this partially as a bridge to pursuing our regional goals. And you know, I did the thing and put the Freddie Sue Bridge up there. But this is an opportunity if we can demonstrate value here and buy into it and get buy-in into it, both from the feds and from the state as well, and from our local stakeholders, particularly the managed care organizations, the insurers. We're hopeful that this will help drive some shifts in policy. And be able to move us forward. And I will say, I know, you know, there's a lot of talk at the federal government level about all of these challenges, but some of the things that we are talking about supporting in this waiver are aligned with where Secretary Kennedy is, with his thinkings around, you know, basic health supports and being able to do that, and with CMS's current position. So I don't think we're that off base. I think we run a little bit of a risk because the waiver is called the health equity waiver from the state. But with that in mind, though, what we're actually doing on the ground is not misaligned with where the federal government is. It's just being able to make the case. So that's where I'll leave it. I'm sorry, I went on a long time.
No, you're good, you're good. We have 8 minutes. Sarah has to leave.
Sorry.
Thanks for coming.
Thanks, Sarah.
And I don't have any other agenda items, just other than to say, Cecilia sent her recollection of the folks you guys wanted to hear from in the coming months, and I did look back on the November meeting minutes, which, you know, I have with me in my binder. And there is a list, so Celia and I will kind of get together and kind of hash this out to see who might be good speakers. Linda, you were the first on the list to speak about oral health dental screenings at Head Start. Linda Clark of Jordan Health will speak. So, you know, we'll see where we go. Yeah, so we're good with the agenda, but are there questions for Albert on the hero and steps forward?
It's so much work.
It's just a huge work, yes.
I think to Sarah's point, we had constituents who reached out to us and being able to help with housing, people getting back to her in a timely manner, just the funding of people saying they waiting on support from FLIPA when like presented here was that you have to upfront the cost. So I think some confusion with some organizations, but then just trying to get these families who like need it now and not getting their paperwork in, and then the constraints that you don't want this and being frustrated with that. So
yeah, you know, it's notable because if you think, well, now I'm dating myself a little bit, but the last Medicaid waiver in 2014 through 18 ish was really hospital system focused, right? It really was. And I think as they were approaching this waiver, DOH really wanted to take a more community focused approach to it. In doing so, though, I think there were issues missed or contingencies missed that are required for smaller organizations, community-based organizations to be able to do things like front big amounts of money for rental assistance, right? Because this is a reimbursement-based program, you know, if you got a front security deposit and 2 months rent for somebody, that's a good chunk of change that a lot of these community-based organizations don't have sitting around and ready to do. There is capacity building dollars that are affiliated with that, but those are only available to the CBOs and not the smaller clinical practices like the FQs and the FQ lookalikes that are participating. So part of our goal here and what we're trying to do at Common Ground is provide feedback both regionally with regards to how we can approach things as an SEN, as a WEO, and as the hero in our region, but also at a statewide level. And what are the policies and things that are standing in the way of us being able to move forward? Some things have shifted, some things have changed that have helped to alleviate some of the barriers. But it is working with government, and it is working with a lot of rules and regulations that they have to adhere to, both at the state and based on whatever their agreement with the feds is to support this work. So yeah, you're flagging all the right things, and it's not misaligned with what we've been doing.
You said the second meeting that healthcare workforce was moved up the agenda. Is that going to the WEO folks now, or who's talking about workforce?
It's a great question, Teresa. Which is the thing you always say when you need a second to but no, it is, you know, still focused on the WEOs do have a role to play in that. I think the original intention of talking about workforce was more broadly talking about clinical workforce gaps and clinical workforce needs. But as we've been engaged in this waiver now, I think more and more the more pressing issue has become, what is CBO capacity to be able to do this, and what does that need? So I think it's been prioritized. And we have been asking the same question. Okay, so well then where do we go to talk about workforce? And how does that happen? And workforce is actually, you know, it's a component of the capacity barrier for the CBOs, but it's not the whole thing.
Right.
You know, so it's a little bit of a different conversation, and they really wanted to focus on that. So we're going to keep talking about where that lands. You know, as Carol was talking about when she was here last month too, right? One of the challenges that they're having is that as the clock is running out, they're not able to enroll folks in the longer term programs with the CPT program. We are continuing. Common Ground does have a workforce initiative with FLIPS, and we continue to do that, which is a broader focus than just the Medicaid waiver piece of that. Yeah, specific to the waiver, it's not clear yet where that's going to land.
Other questions?
Clearly, I could talk about this a lot.
All right, is there a motion to adjourn on time? Wow. There you go. A second? That's great. Yes. All in favor of adjourning, say aye. Great, thank you for another fabulous meeting, and we'll get an agenda set for next month.